Good afternoon, everyone. Welcome to the Higher Education Center for Alcohol and Drug Misuse, Prevention and Recovery's first recovery webinar titled Sustaining Addiction Recovery Among College Students. We are so excited that so many of you were able to join us today for an informative and engaging presentation. My name is Sarah Nerad, and I am the Director of Recovery for the Higher Education Center here at Ohio State, and I am also the Program Manager for the Collegiate Recovery Community. Thank you, Byron, for going over all of the logistics. If anything comes up, please just shoot us a Q&A and we'll get to your question right away about the software. So first, I'd like to go over a little bit about the Higher Education Center. The mission of the Higher Education Center is to help colleges and universities develop, implement, and evaluate programs and policies to reduce problems experienced by students due to alcohol and other drug misuse. The center was reestablished at The Ohio State University in 2014 thanks to the Conrad Hilton Foundation. The Higher Education Center is an interdisciplinary center with strong partnerships between the College of Pharmacy, College of Social Work, Office of Student Life, the Generation RX Initiative, and the Collegiate Recovery Community. The Higher Education Center provides a number of services to colleges and universities. These include technical assistance, technology development, education and training, as well as research and development. So I would like to introduce our presenter, Dr. John Kelly. He is the Elizabeth Spaulding Associate Professor of Psychiatry and Addiction Medicine at Harvard Medical School. He is also the founder and director of the Recovery Research Institute at the Mass General Hospital. The Recovery Research Institute is a scientific enterprise that pushes the addiction recovery agenda forward by conducting recovery research and disseminating and implementing results for the benefit of our communities and the broader society. They have an awesome website, and I encourage all of you to check it out, and it is recoveryanswers.org. So throughout this webinar, there are 3 objectives that he will be going over. So at the end of the webinar, folks will be able to understand the specific significance of the life stage of young adulthood as a major factor in addiction and recovery, be able to describe 3 ways collegiate recovery programs can reduce risk and enhance the likelihood of recovery, as well as briefly summarize the scientific evidence on factors that can help sustain young adult college students in recovery. So with that, I give you Dr. John Kelly.
Thank you, Sarah. Can you hear me okay?
Yes, we can.
Very good. Thank you so much. Delighted to be here. Thank you for the opportunity and the invitation to present today. Hopefully, I am coming through loud and clear, and so that everybody can hear me. So good afternoon, everybody. All right, so my topic today is focused around sustaining addiction recovery among college students. So let's begin with just a rough outline of what I'm going to talk about. I'm going to talk a little bit to begin with about dealing with stigma and discrimination. This is a big issue in addiction, and I'll tell you why. And then I'll talk about the life course perspective, why that's important to take a life course perspective when we think about high volume, high burden diseases like substance use disorder. And then I'll go on to talk about conceptually how we understand relapse, remission, and recovery, and how that pertains to collegiate recovery and sustaining recovery in college students. And then finally, I'll talk about some ways that we can build what is commonly known as, or increasingly known as, recovery capital. These are resources which can be brought to bear on remission and recovery from substance use disorder, including some specific examples of strategies to sustain recovery. So what about stigma and discrimination? Well, what we know about addiction, we can think about stigma as an attribute, behavior, or condition that is socially discrediting. And it turns out, we have lots of these stigmatizing conditions and problems in society, right? But it turns out when we look both nationally and internationally at these stigmatizing conditions, addiction tends to fall right at the very top of these lists of stigmatized conditions. It's one of the major reasons why people don't seek help for a substance use disorder. So they tend to wait and get sicker before they're more desperate, unfortunately, to get help. This is why there's been a movement now for early screening and brief intervention, for example, in primary care, to help intervene earlier. So what happens is people delay because they feel embarrassed and ashamed about their condition. And when we look internationally too, we find that addiction is possibly the most stigmatized condition in many different societies. There was a World Health Organization study which looked at the 18 most stigmatized conditions in 14 different countries. And what they found, and this included things like being a criminal, being HIV positive, having AIDS, and the number one most stigmatized condition was drug addiction, okay, illicit drug addiction. Number 4 out of this list of 18 was alcohol addiction, okay, so 2 of the top 4 was pertaining to substance-related conditions. So this means that they are heavily stigmatized, whether we're always aware of it or not. I seem to have flipped a slide there. Hold on a sec. Okay. Whether we're aware of it or not, and it means that only about 10% of people with a substance disorder actually access treatment in any given year. So one of the things that's important in relation to stigma is how we talk about and how we frame these conditions. So I was very honored to be invited to the White House, and this slide kind of depicts that event, which was at the first ever National Drug Policy Control Forum that was held in the United States. It was held on December 9th, 2013. And the purpose of that particular event was to mark a shift away from the war on drugs and towards more of a public health view of treating substance-related problems. And the reason why I was invited was because I've done a lot of research looking at terminology and words and how we talk about it and write about addiction and how that may relate to biases, to implicit cognitive biases. That means unconscious cognitive biases that may be induced by certain words. And this pertains particularly to stigmatized conditions like addiction. And some terms are more stigmatizing than others. And some of those terms, for example, I'm sure you've heard things like substance abuse and substance abusers. Other ones would be less stigmatizing in my mind, which would be describing someone as having a substance use disorder, for example. And so there may be different kind of connotations which may be evoked by each particular term. And so what I wanted to look at was experimentally look at whether these terms do in fact induce different kinds of biases in terms of how people are viewed with these conditions, depending on how they're described. Of course, this notion of a stigma has been carried forwards in terms of recovery messaging. Right. So even though people often describe themselves as having, I'm an alcoholic or I'm an addict, the way that it's been recommended that people, when they talk publicly about recovery, is they describe themselves as a person in long-term recovery. And there's a reason why that was recommended, why that particular style of communication was recommended, because it evokes different connotations and a different schema that's activated in people's minds when they hear I'm a person in long-term recovery compared to I'm an alcoholic or an addict. So in the same vein, what we wanted to look at, well, experimentally, what does this do? If you actually expose people to different terms, does it induce bias in terms of whether people should be punished or treated? We know that in terms of stigma, there are 2 main factors which contribute to stigma. One is cause and the other is controllability. We tend to be more compassionate with people who are who have a condition where we say, well, they can't help it. They can't help it and they can't control it, right? If it's not their fault and they can't help it, then we're more compassionate. If it is their fault and they can help it, then we would term it kind of willful misconduct and it should be punished versus treated. What we've learned about addiction is that about half the risk of addiction is conferred by genetics. So just by virtue of what you're born with influences risk very dramatically. As one of my colleagues said, it's not how people become addicted, but how come we're not all addicted, given the potency and rewarding aspects of many drugs like alcohol, for example, to which the population is exposed. The other thing is that with regards to alcohol and other drugs on the brain is that it does produce very profound structural and functional alterations in the brain, which make it very difficult for people to self-regulate impulses to use drugs over time. So this classic idea of impaired control over a reward-seeking behavior from which harm ensues. So even though people suffer very severe consequences, they are unable to stop their substance use. So coming back to these two terms, what we did in this study was actually look to see whether it really mattered whether people were exposed to a different term. We chose two terms. We described the same person using these two terms. We described Mr. Williams as a substance abuser in one variant of the vignette, and in another variant of the vignette, we described him as having a substance use disorder. Otherwise, the vignettes were identical. And we randomly assigned these vignettes to 561 doctoral level clinicians. So these were mental health psychiatrists, psychologists with doctoral degrees working in addiction and mental health. Half of them got the top vignette and half of them at random got the bottom one. Interestingly, the individuals who received the top vignette describing Mr. Williams as a substance abuser were more likely to view Mr. Williams as more deserving of punishment, less deserving of treatment than the exact same person described as having a substance use disorder. In a follow-up study, what we did was we did a similar study in the general population. We found even bigger differences when the person was described as a substance abuser versus having a substance use disorder. What this means is that even when we're not aware of it, even implicitly, unconsciously, we may be biased by exposure to certain terms. So certain terms like abuser, we strongly recommend not using those terms and instead describing and using language which is more in keeping with a public health approach and more in keeping with a medical malfunction that we know happens in the brains of individuals who are exposed to substances over periods of time. For example, it's a good idea that we learn from our colleagues in other fields. For example, people with eating-related problems are always described as having an eating disorder, never as food abusers, right? And we should do the same in the substance use disorder field, describe individuals as having a substance use disorder, not as food abusers. If we do this, we're likely to reduce stigma and increase the public's perception of these conditions as in need of treatment as opposed to punishment. This is an article that we just published in the American Journal of Medicine in which we actually talk about these different terms and why it's important. We call this Stop Talking Dirty as a play on words in the sense that oftentimes you hear addicts being described as being clean or dirty, as urines coming back clean or dirty. We don't use this kind of language in any other area of medicine. So it's important that we understand what the potential implications of using such language is, and also begin to use language which is more in keeping with a medical condition with the medical conditions that they are. So moving on to the life course, why is it important to take a life course perspective? Well, we know that the life course has different stages of development, right? So there are different biological, neurobiological, as well as psychological and social changes that go on across the lifespan. The kinds of risks and protective factors when you're a child and when you're an adolescent, as opposed to a middle-aged or a senior citizen, you're going to have different kinds of roles, responsibilities, life context, as well as physiologically and neurophysiologically differences, which are important to take into account when you're looking at a public health view of addiction and recovery. when we think about addiction, we have a huge problem. It's the #1 public health problem in the United States. We all have been hearing too much recently about the opioid epidemic, about 100 people dying every single day from opioid overdose. This is just a part of the problem, even though we've been hearing more about it. Alcohol kills 100,000 people every year in the United States. 3.3 million deaths around the world annually are caused by alcohol, and about 350,000 deaths of all illicit drugs combined around the world. Importantly, about 320,000 young people between the ages of 15 to 29 die from alcohol-related causes. What's noteworthy here is that when you look around the world and you look at causes of disability and death and premature mortality, among young people, almost entirely, you can see these green bars. The green bars represent alcohol. The light blue represent illicit drugs. And these are for 10 to 24-year-olds. If you look in the bottom part of this graph, you'll see 15 to 24-year-olds there. And you can look at seeing different regions of the world. But about 80 to 90% of all the disability, premature mortality in this age group around the world is caused by alcohol, followed by illicit drugs. So if you're going to get sick or die, it's pretty much only because of alcohol and illicit drugs. The good news is, and what we've realized is that actually if we do something earlier, just like other kinds of illnesses and diseases, the earlier we intervene with addiction, destabilize emerging addiction patterns, the earlier people achieve full sustained remission. So what is it about emerging adulthood that's particularly important? We know that emerging adulthood confers a lot of risk. We see that it's a time of change in life where people are leaving home, typically going to college or getting their own place, getting a job. There's a lot of identity exploration and exploration of new roles. There's kind of a desire for adult things, including alcohol and experimentation with other drugs. We see this in the population. There is engagement with new social networks, which can be introduce new risks, etc. And there are physiological changes in the brain which are going on, particularly in the prefrontal cortex, which is associated with delaying gratification, appraisal of risk, as well as controlling impulses and regulation. We know that this transitional age stage of 18 to 25 is one that's fraught with all kinds of risks in terms of psychological distress. Here we can see from population data that 18 to 25-year-olds are more likely to suffer high rates of distress than at other times in our lives. Also have the highest rates of moving around a lot, right? 18 to 25-year-olds tend to move around more, as well as 25 to 29-year-olds. So young adulthood is a time of instability in that regard. It's also the highest, have the highest rates of substance use disorder and substance-related problems, as well as other kinds of psychiatric distress. One of the implications for recovery of young adulthood is that sobriety supportive and sobriety conducive contexts are the least available for young adults, because it's at this time in the life stage that the highest rates of alcohol and other drug use occur. So if you're a young person trying to get sober and sustain recovery, this is going to be the hardest time because of the lack of support for sobriety among your peer group. And this is a study that was done over 9 years, and they looked at this empirically to look at past year remission from substance use disorder by gender and age over a 9-year follow-up. What they found was that the younger age group had a harder time getting and staying in remission. They also found that the younger age group was significantly more likely to have people in their social network who encouraged substance use. And as I was saying, this is the hardest time because you have more people around who are using alcohol heavily or other drugs, experimenting with other drugs, so it makes it harder to find venues that are supportive. Perhaps the most significant and difficult environment in this regard is college environment. There is a kind of an implicit rite of passage a cultural phenomenon in college where the ritual of heavy drinking is pervasive, as well as increasingly use of other kinds of drugs. This means that it's more difficult than it would normally be if you're a college student in recovery, returning to a college environment. In this study, this is actually looking at help seeking by college status, by educational status. It was a large sample of 11,000 young adults who are either full-time or part-time college students or non-college students around the country. What they found was relative to full-time college students, if you were a part-time college student, you had about 2.5 times the likelihood of seeking treatment for your alcohol use disorder. If you were a non-college student, it was close to 3 times the likelihood of seeking treatment. And if you're a non-student, you're about 1.67 times more likely to seek treatment relative to full-time college students. So if you're a college student with an alcohol use problem, you're just significantly and much more less likely to seek treatment for that problem than people who are either part-time, non-college participants or non-students. This is very significant and important because education is a vital component in recovery capital, in building hope for a better future for ourselves, and also for longevity. It turns out that education not only affects our psychological status, it also affects our physiological status. And this longitudinal study, this is the study of adult development. It's the longest study of human development ever conducted. It was conducted here in Boston and using 2 different samples. There was a disadvantaged sample from South Boston, and there was an advantaged sample who are Harvard graduates. And what they found was that the disadvantaged lower SES group was significantly more likely to be disabled or dead at a much earlier age. And this is what this graph on the right shows. But what was interesting was that if the men who were in the disadvantaged group got a college education, they looked very similar to the group that were the advantaged group. Now, we can't infer pure cause and effect here because these are correlational data. But it suggests, and there are other data to support the notion, that education is vital not just for recovery capital, but also building hope for a better future for ourselves, as well as health and physical health and longevity.
Okay, so when I was thinking about this webinar and kind of the information that we were being presented with, I really thought about how helpful it would be to making the case for support on a college campus and for the need for a collegiate recovery community. So I was wondering, Dr. Kelly, I know we just talked about, education as recovery capital, as life capital. So how would we describe that really simply to our college administrators, to our bosses who might not totally understand recovery capital and social capital? What would be a few sentences that we could say to them to get them to really understand that education is recovery capital for these students?
Well, I think education, all that education provides, the enrichment in one's life, knowledge-based self-esteem, the hope that it instills, the hope for a better quality of life, the ability to get a job, to move on with one's life, all of those are a function of education. And it's very important when people typically have had histories of addiction problems, their self-esteem and hope is low to begin with. But giving people hope that they can get an education and, enter an environment which would ordinarily be a very high risk one for relapse for individuals in recovery, to be able to provide a context that supports their recovery and lowers the risk of relapse so they can get an education, I think is critically important. And that's why we've seen these programs grow rapidly around the country.
That was perfect. How would you say some of this to a donor or potential funder?
Well, I think it's one of the most important things that we can do to support recovery in terms of collegiate and high schools. Just because the environment is so critical, as I'll show you in the next sections, that the environment, the social environment, and the cues and triggers that come with the social environment are so critical to recovery that providing these collegiate recovery entities the context for recovery, the support that these things provide, they provide a safe haven where people can feel comfortable going back into an environment where they can get an education. And otherwise, they would not be able to do that. You know, they might shy away from it just because of the risk. So it can make literally all the difference between someone returning to college and building hope for a better future versus not. So that's why I think these collegiate recovery programs and supports are so critical.
Thank you. That was really helpful. I know some of my donors are, in recovery or they have a loved one in recovery, so they really get it. But other folks that I talk to don't quite understand recovery and why we should, support this and support it. So I think being able to take some of this research and the work that you've done and put it in lay people's terms is so helpful for all of the folks across the country that are trying to start collegiate recovery programs. It's really helpful. And I wanted to go back to a piece on the language. When I think about the Higher Education Center, when we were trying to come up with a name for that, the old center had abuse in the title, which we know is a word that we're not really wanting to use anymore. And so we struggled between use and misuse, and I think that we still have a long way to go on college campuses in terms of changing that language. Do you have a sense for are college campuses ready to change how they talk about substance use prevention? Because I feel like a lot of them still use abuse.
Yeah. No, it's very common, and language is so automatic. And this is part of the issue, right? Is our language is necessarily automatic. It's highly conditioned. We don't often think, we don't, if we had to think about every word we said, maybe we should think more about what we said. But if we had to think about it, we'd be a lot slower at communicating. So we're very rapid at communicating. But one of the problems with that is that we're in habit, in other words, an unconscious habit of communicating using certain words. So it does require more consciousness around the kinds of language that we use. It's been done in other fields. It's been done in the areas of race and ethnicity. It's been done in the mental health field. For example, the Person First Language initiative has been around for decades in mental health. Instead of describing someone as a schizophrenic, for example, now the culture is shifting towards describing that individual as a person with schizophrenia or a person suffering from schizophrenia. And the same is starting to happen slowly but surely in the addiction field as well. But it takes time, and nobody's kind of ready for it in a sense that, we're just not used to using these terms. But we can certainly get used to them, just in the same way as in the eating disorders field. Everybody knows eating disorders as the eating disorders field. We don't call people with eating-related problems food abusers. And when you make parallels like that, it makes sense that we should be using different terminology. And I think especially now that we are moving away from the war on drugs and towards hopefully a more effective public health approach to addressing these endemic problems in our society and on college campuses.
I had a question, and they asked, how can we shift people's perception of recovery? One donor told me recently, it's a personal problem. So how can we shift people's perspectives to it being a systemic issue while still being compassionate?
How can we shift the public perception of it being both an individual problem and a systemic problem?
Right, and being compassionate that whole time.
Hmm. Well, I think there's a couple of things. I think it's two-pronged as I see it. One is educating people around the true nature of addiction. We've learned a lot in the last 25 years of what happens to people, what happens to people's neurocognition and neurological functioning when they are exposed chronically, when the brain is exposed chronically to alcohol and other drugs. That really radically impairs brain function and structure. So one is educating people around that. But the other important thing related to that is that people do recover, is that when people abstain, their brain actually makes very large improvements. They don't always get back everything that they've lost, but they get back a very large degree of that cognitive capacity and functioning. That's the good news. The other thing about beyond education regarding the nature of addiction and recovery is the putting a face and a voice on recovery. So we are surrounded by people in recovery. There's about 25 million people estimated in the United States who are in recovery from a substance use disorder. That means we have neighbors, we have co-workers, we have co-students and colleagues who are in recovery we don't know about. And this is part of the problem in terms of stigma and shame. Ironically, even when people get into recovery, they're still very reticent at disclosing it because of the public stigma associated with these conditions still. So there's been a national movement to support people talking about their recovery and saying, I'm a person in long-term recovery, and describing that so that people get to know and people in recovery, which then really destroys the kind of stereotypes that people have about people who've had alcohol and other drug problems. Yeah, so conceptualization. So I'll talk a little bit about relapse prevention, remission, and recovery. What we've learned about the course of addiction, the clinical course of addiction for people who are on the severe end of the spectrum who are seeking treatment, we know that the course typically is a long one to recovery. It can take years often before, after people start seeking treatment, before they achieve 1 full year of sustained remission. And in some estimates in adult samples, it can take up to 8 years to get 1 year of full sustained remission. So we're talking about a long-term time course in terms of remission after people start seeking treatment. The good news is that after people start seeking treatment, they start to make progress. So they may get a few months and then have a relapse. They may get 6 months and then have a relapse, may get 9 months and have a relapse, but eventually get to 1 year of full sustained remission. The good news is that addiction actually is a good prognosis disorder. Approximately between half to 2/3 of people who meet criteria for a substance use disorder will achieve full sustained remission. It can take a while for some people to get there, but the good news is that the majority of people do achieve full remission. But why do people have a hard time staying sober in remission early on? This is a relapse curve that we typically see after an intervention. So after people have received a treatment, some kind of treatment for a substance use disorder, we see a curve like this. Within 90 days, approximately 2/3 of people, on average, will have picked up alcohol or another drug within that time period. So what's going on? Well, one of the things that we've realized is that addiction is very similar to other kinds of chronic illnesses. So when you look at other chronic illnesses in the medical area, like type 1 diabetes, hypertension, and asthma, for example, the degree of relapse or adherence to treatment is very similar to these other kinds of chronic conditions. Oftentimes we've been viewing addiction as an acute condition with an implicit expectation that people after a single episode of care should be able to achieve full sustained remission for the rest of their life. And this is not in keeping with what we know and have learned about addiction. Another reason why it's difficult to stay in remission is because of this what we call reward bias. So when people early on in recovery, there was a lot of brain changes that have gone on as a function of exposure to substances. And when people are in recovery, those changes take time to change. The brain takes time to recover. Of course, the rewards of substance use are immediate, potent, and predictable. And the rewards of recovery are delayed, diffuse, and variable. So what we need to do is shift this balance, right? So there's a bias towards relief now with a question of maybe suffering later versus suffer now with the idea of better times later on. And so oftentimes early on in recovery, there's a bias towards, I want that relief right now, and I'm not sure about the suffering later. And what we try and do in treatment and recovery support services is to tip the balance by providing medications, for example, but also support, clinical support, peer support, collegiate support that can help people to get through the earlier tough times that are inevitable when people are recovering from the disease of addiction. And so, you know, these areas of the brain, we can think about these as bottom-up or top-down kinds of treatments. Bottom-up would be a medication, top-down would be psychosocial treatments like CBT and 12-step. We know that these behavioral treatments change the brain just in the same way as other kinds of cognitive rehabilitation models or medications. They alter the function and the structure of the brain from the outside in. So in order for people to recover from this disease of the brain, which affects the neurocircuitry of reward, memory, motivation, impulse control, and judgment in those areas of the brain I just showed you, it requires people to make accurate risk appraisals and adaptive decisions over time. And it's a very demanding and effortful process. It requires constant vigilance, which can lead to exhaustion. There have been models of stress and coping around for a long time. Hans Seeley, back in the 1950s, developed this model. He wrote a book called The Stress of Life, and in it, he described what became known as the general adaptation syndrome. And this was a syndrome that organisms go through in response to stress. There is an alarm stage where people or the organism becomes very heightened in their vigilance and response to the stressor. There is a period of resistance to the stress, and then there's a period of exhaustion. Now, this fits the model of addiction as well, in part because when people have an event, some kind of negative consequence, there's usually an attempt to stop or cut down. In other words, there is a resistance phase. But people find it very hard to keep up that level of resistance, and so they become exhausted and then end up picking up the drug or alcohol or another drug and resuming use, which leads to a cycle of problems. There's been experimental work, actually, which has shown this exact same phenomenon experimentally. What Steve Muiraven has done and Baumeister, what they did was actually look at the giving people cognitively demanding tasks which are stressful, in other words, exhausting them cognitively. And what they found was that people drank much more. They were unable to resist or less able to resist the temptation to drink alcohol when they were more cognitively exhausted. So one of the goals of recovery is to find ways to replenish these cognitive resources and prevent exhaustion and inhibit thoughts and impulses to use substances over time. When we think about recovery, the recovery construct in this regard, it's really the same as the addiction construct. They really come to understand it as a two-pronged construct in the same way as addiction is. Back in the 1970s, Griffith Edwards described addiction as a biaxial phenomenon. And he said, basically, there are two axes to addiction. One is the addiction itself, which happens inside the person. And the other axis is the consequences that stem from the addiction. In the same way, and there's a reciprocity between these two. So the more severe your brain becomes addicted, your brain becomes addicted, the more consequences you have. But also, the more consequences you have, the more likely that the addiction problem will be prolonged. And this is mediated through stress and coping. In the same way, you can think about remission or recovery in the same biaxial way. It has two axes. There's remission from addiction and the consequences of that remission, and it's a reciprocal process. So as people get and stay in remission from a substance use disorder, they naturally start to feel better. They start to look better physically. They also start to accrue other kinds of positive things in their life. But also importantly, it's a reciprocal process, just like the addiction syndrome itself. So we can actually increase the chances of remission by providing more recovery capital, in other words, medical stabilization, but also education, housing, social relations, and so on. That will increase the chances of ongoing remission. And a big factor in this is different kinds of recovery support services, one of which, of course, is collegiate recovery support programs and recovery high schools. Why? Because these are venues that, as I mentioned before, are high-risk venues. They are difficult to navigate and cope with for people early in recovery because there are many other young people who may or may not have serious problems with alcohol and drugs, but are nevertheless experimenting and using, making it very difficult to find sobriety-conducive and sobriety-supportive contexts. There are other entities, of course, that have been around a long time. There are mutual aid organizations like AA, recovery community centers, as well as clinical efforts to provide recovery supports over time. So we've seen the growth of these collegiate recovery programs around the country because of these phenomena and these facts that I'm talking about here today. There is Association of Recovery in Higher Education, and these programs have been around for quite a while, and they really help. They help young people get and stay in recovery. When you look at relapse rates for college students who are returning, who are involved in these collegiate recovery programs, the relapse rate or reoccurrence of substance use disorder is extremely low. So this is good news. It's also apparent that students who go back to colleges and to higher educational settings and are involved in these collegiate recovery programs have higher GPAs than the average student body. So that's the other good news. They're achieving higher academic performance and staying sober in a high-risk environment. That's the kind of outcome that we want. When you think about collegiate recovery support, it provides a setting, a venue that's protective and that buffers against the risks that are apparent in the community, in the collegiate community on a larger scale. There are 5 types you can delineate of support. There are emotional support, like having someone to confide in. Instrumental support, this can be services. Informational support, that can be guidance, help with problem solving. Companionship support, this is a sense of belonging that's so important to people. And then there's validation and feedback and social comparison. And these are deemed to be 5 kind of major ingredients of social support. So how might recovery support services like collegiate recovery programs help reduce relapse risk? Well, we know there are common precursors, and I've mentioned some of these, triggers and cues in the environment. So these are people, places, and things in the environment which increase the risk of relapse to substance use. There are also stresses. So this can be feeling depressed, sad, angry, frustrated. This can also increase the risk of relapse. And then there is also drug-induced relapse, and these are exposure to a little bit of a drug. Could be a joint or a drink, so a little bit of a priming dose, and that can kindle craving and increase the risk of relapse. So the way that these recovery support services like collegiate recovery programs work to reduce relapse risk is by changing the social environment, which in turn shifts exposure to these cues and stresses, which means that it also helps to build, through the social environment, psychological coping skills and self-efficacy, and ultimately change neurological functioning, which helps to buffer against relapse risk. Mutual help organizations are often a cornerstone of collegiate recovery programs. They are the most commonly sought source of help for alcohol and other drug problems in the United States. And they've been around a long time. They are freely available and widely accessible. And importantly, they help to remotivate people over time, just like treatment. In fact, what we've found is that mutual help organizations like AA and NA and groups like that help to maintain motivation over time by re-exposing individuals to memories of their prior experiences, which can easily be forgotten. Those memories can be suppressed, repressed, or they can decay over time. And this is the notion of kind of keeping it green. When people talk about what things used to be like for them in terms of their active addiction and what it's like now, that comparison leads to an appraisal that facilitates ongoing recovery. They also provide access to a new social network, and this is what we've seen in terms of the major mechanisms through which mutual help organizations like collegiate recovery programs in a similar way do, which is to change the social environment and exposure to cues. There are a lot of these mutual help groups, of course, that have been around for a long time. AA is the most famous, but there's been others based on the 12 steps template that have come along as other drugs have become more prevalent, but also other ones that have come along like Smart Recovery and LifeRing, which are non-12 step, which have grown, although we don't know much about these other groups in terms of research. In part, that's because there's been a bit of a catch-22 where these other programs like Smart Recovery and LifeRing haven't grown as rapidly because they're small, so clinicians tend not to refer to these groups, and so they don't grow. And so there's a bit of a cycle there. They don't grow, and then clinicians are less likely to refer. So we're in the process now of trying to do more research on these other groups so that we can increase their visibility and increase the options for people in and seeking recovery. We know from the evidence base that's accumulated in the last 25 years that participation in groups like AA actually produce long-term better outcomes. What about young people, though? This has been a question mark in terms of young people and participation in mutual help, in part because there are much fewer young people's meetings and young people in recovery. Only about 13%, for example, of NA and AA members are under the age of 30, and only 2% under the age of 21. So this means if you're a young person trying to access recovery resources in the community, you might not be able to identify with other people in those groups just because they may have different addiction histories, they may have used different types of substances, they may have had different types of consequences than young people. And there's an explicit spiritual focus which may be less appealing to younger people from national surveys than they are for older people. So what do we know? We've done lots of studies in this area. What we know is that young people do go and they do benefit. That's the bottom line. This is an 8-year prospective study. We followed 166 adolescents from average age 16 up through average age 24. So this was over the transition to young adulthood. And what we found was that people who abstained across this 8-year period were significantly more likely to be participants in AA and NA. What we found also is that the real-world effect of that was that for every meeting that young people attended over this 8-year period, they gained an extra 2 days of abstinence. So what we found, in essence, was that roughly 3 meetings per week was associated with complete abstinence over time. We have replicated this kind of study with young adults. These are average age 20 to 21. These are 18 to 24-year-olds. These are 300 young adults. Again, what we find is that young people are able to access these resources in the community after treatment. They do well. Attendance is associated independently with better outcomes over and above all kinds of other factors. And also involvement, active involvement, seems to be the way to go over time. This means things like getting a sponsor, working the steps, getting involved in service positions in mutual help organizations. What we also find when we look at studies is the, coming back to this slide, is that there's an additive effect. Over on the left-hand side here, you can see in this cohort of 303 people, 42% were abstinent across the year after treatment. But they differed in terms of how much treatment and mutual help involvement they were engaged in. So you can see the 14.3% there. Those were individuals who had low sober living environments and low mutual help participation. The next bar is low sober living environments and high mutual help participation. And then you have the highest abstinent rate among those who were high in sober living environments and had high mutual help participation, of whom 73% were continuously abstinent across the year after treatment. We've seen this among young people. These are adolescents, 14 to 19. Again, a similar relationship in terms of participation and benefit over time. But what about young people's meetings in particular? Sometimes we think about, well, should we be referring young people to young persons meetings specifically, as opposed to AA or NA groups in general? And this is a study where we looked at that specifically, and we looked at the age composition of the most frequently attended meetings for adolescents after treatment. And what we found was that the more teen-like the meetings were, the better the adolescents did. And this is a linear relationship you can see here in the blue bars in the first 3 months after treatment. So you went from all adults up to all teens. What's interesting, though, is in the next 3 months, you see a similar but slightly different relationship in that as the group, the NA and AA groups that these adolescents attended become more teen-like, they do well up to a point, but maybe there's a diminishing return over time. We replicated this in a young adult sample, and this became clearer what was going on. What we found here is that young people, these were young adults, who are going to young people's meetings in the first 3 months, actually did better if they went to meetings where there were more young people present. But over time, just like in the prior study that I just showed you, what we found was that young adults who didn't get involved, didn't spread their wings and get involved in other groups and stayed with the young persons group didn't do as well over time as those who had a mix of participation in groups that were both young people focused as well as other groups. So this is an interesting finding in that it's important early on, maybe for purposes of identification and engagement, that young people find groups where there are other young people present. But over time, it may enhance their recovery to get involved in groups where there's other people with longer-term recovery and life experience. One of the other things to remember about mutual help from a public health perspective is that it's very cost-effective. What we found in both adult studies and adolescent studies is that participation in meetings tends to increase outcomes, it increases remission rates, abstinence rates, and it reduces healthcare costs. And in this study, a 7-year prospective study with 400 adolescents conducted in California, what they found was that for every AA and NA meeting attended, the health system saved about $150 on average over that 7-year period. So what have we learned about how young people benefit from participation in these groups? I showed you this graphic before. So again, this social network that's apparent in collegiate recovery programs is also apparent in mutual help groups. There's a lot of commonalities between groups like AA and other kinds of formal treatment groups, as well as the social context of collegiate recovery programs. Now, these therapeutic factors, these curative factors listed here, are from Irvin Yalom's group therapy theory. Now, these are what are deemed to be the therapeutic factors which are operating in professional group therapy. But you could also argue these are the elements that are operating in collegiate recovery programs as well as mutual help organizations. So when people participate in mutual help as well as collegiate recovery, there's a sense of universality. That is a sense of belonging and that we're all here together with the same common problem, with a common solution that we're sharing together. There's altruism, there's installation of hope, there's imparting of information. The recapitulation of the primary family experience is less applicable to these settings, but there's development of socializing techniques, there's imitative behavior, there's cohesiveness, there is existential factors going on, in other words, gaining new meaning and purpose in one's life. There's catharsis, that is to say, expression of emotion and processing of emotional feelings, interpersonal learning and self-understanding. So these are all elements which are operating in collegiate recovery programs as well as mutual help groups. In studies that we've done where we ask young adults, what do you get out of 12-step meetings? What do you find helpful? What we find is that the largest and most important factor, we've done this in adults, in adolescents and young adults, we find that the most prepotent factor is this sense of cohesiveness and universality. This is probably the strongest therapeutic factor, and this is that sense of belonging in those elements of social support that I mentioned earlier. The next biggest one was installation of hope, the possibility that I can change and that I can get well and stay well. Why do I think that? Because I can see it among peers who are just like me because of this sense of universality and cohesiveness. So these are strong, powerful therapeutic factors. I mentioned this notion of social factors driving, being so prepotent in terms of recovery. This is a study where we compared older adults and younger adults in terms of how they benefited from Alcoholics Anonymous participation. This was a very large study of 1,726 individuals with alcohol use disorder. What we found was that there were many mechanisms through which AA benefited people over time and led to increased rates of recovery. But young adults differed in the way that AA worked for them. And this is interesting, is that for young adults, AA helped them reduce their high-risk social network more so than their older adult counterparts. So a major kind of therapeutic mechanism for young adults in particular is the benefit of groups like AA and NA in helping to reduce exposure to high-risk social networks that can induce or increase the risk of relapse. So in summary, just to finish up here, I would suggest that, as I mentioned in the beginning regarding the stigma and terminology, is to adopt a lexicon and terminology that lessens stigma and discrimination, and that is in keeping with a public health approach to addressing addiction. We know that young adulthood in particular confers the highest risk for substance use disorder, psychiatric disorders and distress, transitional living, and poverty. And recovery supports during this life stage are at a premium. They're even more at a premium in college settings. Providing recovery supportive context, such as collegiate recovery support program, can help returning students enhance recovery capital and reduce the risk of exposure to high-risk environments. Augmentation of collegiate support programs with mutual help organizations is a cost-effective way to enhance the chances of remission and recovery. And mutual help organizations can aid youth recovery and work by enhancing and maintaining recovery motivation and by facilitating, most importantly, these changes in the social networks. Do we have time for questions?
We do, and we've had some awesome ones submitted. So I saw, Matt, you asked some questions about the research. I know you'd asked if you could slow down and go over it a little bit more. So if you could maybe submit a question specifically about something that you want more clarity on, we can make sure we get that answered. So another question we had was, what do the majority of treatment for young adults look like? Is it 12-step based or counseling, medication-assisted treatment, and how involved are physicians usually? This person is inquiring about addiction doctors, and they're kind of a minority, that it's not very balanced. So what can we do with the medical field and helping in all this with treatment and supporting young people?
Yeah, it's a mix. It's a mix of all of the above. So there'll be, depending on the type of nature of the substance use disorder, for example, if it's an opioid dependence, then oftentimes people will be prescribed buprenorphine, naloxone, or in other words, Suboxone or methadone. If they have a longer history, more severe, et cetera. As well as other kinds of psychosocial treatments. There can be group treatments, individual therapy. So there'll be a variety of different combinations depending on where you go and where you get treatment. And then depending on, there might be medications for alcohol use disorder prescribed by a physician or a clinician with prescribing privileges, as well as other kinds of, 12-step integration, referring people, linking people to community supports like AA and NA. So all of those things will be apparent. One of the things that's happening, of course, with healthcare reform is that there is now a much greater stimulus with the healthcare reforms that are going on and will be implemented over the next 10 years, whereby more and more people are going to have access to addiction care. And a lot of that care is going to take place in primary care settings, in primary care environments where there may be medical teams which are designed to treat the whole person, behavioral health as well as medical health.
We did a screening of the anonymous people last night, and we had a really interesting discussion about, emergency rooms and that they're rated based on patient satisfaction, and pain is one of the vital signs. And so it's really fascinating when you start to think about the medical field and how they play a role in all of this. And another question that we received from Michael is, are there any quantitative data about the positive effects of education in early sobriety outside of data generated by collegiate recovery programs?
Not that I know of, but that's what we need. We need more of that in terms of real hardcore quantitative data on that. Yeah. So I'm hoping that there are people studying collegiate recovery programs. It's been challenging to get funding to do it. There's a lot of competitive, funding priorities that National Institutes of Health sponsor. My bias, of course, is that we need more of this kind of research because I think these programs are so critical and vital to young people and increasing recovery capital. So I'm hoping that down the road here in the next few years, we'll have more studies with harder edges to be able to determine that. Great question.
Sorry, I loved when you talked about the 12-step meetings. I remember when I first heard you present some of this, and you talked about, each meeting is about 2 days of abstinence, so you should go to 3 meetings a week. And so I sat there, being an alcoholic, thinking, okay, well, how many meetings do I need to go to for the next few years so that I, at some point, don't have to go to any, that I would have, stockpiled enough. And I think that's a great recommendation about meetings. It's just funny how I interpreted it. How can I get around the rules? But you talked about, young people, and, we do really well initially going to meetings with a bunch of other young people, but at some point there's a diminishing return on that. And for my own recovery, I saw that. I loved being around all the young people, and I'm grateful that Houston, Texas, where I got sober, we had a bunch of young people. But then after a while, I was like, you know what, like I need some folks to teach me how to be a grown-up and how to be a woman. And so when I think about collegiate recovery programs, they can be very insular and kind of exclusive, to where sometimes we only hang out with other CRC students, we only network within that community. And I often wonder if, we do a disservice to students when we do so much just within that community. So what, because you kind of mentioned that about the diminishing effect. So, what do you think we need to do a better job of helping them kind of mainstream and to survive after they leave a recovery high school or collegiate recovery program, so that they know how to do some of this stuff on their own?
Yeah, well, I think it's an important point. I mean, these are a couple of studies that we've done which kind of seem to suggest this, and it kind of makes sense that we all need, we need kind of mentors that have more life experience, maybe longer sobriety experience at different stages. And while collegiate recovery programs, if they are mostly focused around the same age group, it maybe would be advantageous to recommend what we're talking about here, which is to also expand beyond your own peer group to seek out people with longer-term sobriety and more life experience, from whom you can get, more knowledge and skill to be able to cope with the bigger dimensions of life as you progress in yourself and your own recovery over time. So I think making that a point, Sarah, would be maybe fruitful in terms of mentioning that, emphasizing that.
We had a question about how can students not in recovery be engaged to support recovery efforts with peers on a college campus?
Well, I think there's probably indirect and direct ways. I think if it'd be wonderful if we had more people who were more supportive of this, and I'm sure there are a lot of people out there who want to support these efforts and individuals in and seeking recovery. So I think one is to, begin the conversation, talk about it with their friends, and emphasize why these things are important. There's also more directly, of course, it would be to actually approach the collegiate recovery programs, if you have one at your college, to volunteer, to get involved, to help out. And if you don't have one, maybe to advocate for one on your college campus, so that other people can benefit from these great programs.
Another question that we have is, in your opinion, is any one mutual help organizations, like AA versus NA, more effective for young people?
We don't really know. I mean, we just published a study where we looked at, it was in a young adult sample. We didn't look at it in regard to age, but we looked at it in regard to primary drugs. So if you had a primary drug dependence other than alcohol, did you do better in NA versus AA? So we looked at it from that perspective. And what we found was that people who had a primary drug use disorder that was not alcohol did as well in AA as they did in NA over the year after treatment. They went to more NA meetings for those with primary drug dependence, but they also went to a lot of AA meetings, and there was no difference in whether they went to more or less NA or AA. They benefited just from 12-step participation. Many of these individuals, of course, also had a comorbid alcohol use disorder, although that was not their primary substance. So looked at it in that regard, but we did not. I can't speak really to the other aspect of what we know about, and I truly don't know. I mean, I don't know which one would be better in terms of young people. There's a slightly younger crowd on average in NA than AA, but not by much. A couple of years on average. So I can't really speak to that, but that's a good research question to try and figure out.
So do you think that CRC should be 12-step based?
Not necessarily. I think that's a model that has been adopted in a lot of these CRCs, but I don't think they have to be 12-step based. They could take on another orientation and I think still function well. There's a lot of overlap, of course, in the kinds of under the hood, under the surface, between 12-step and cognitive behavioral therapy, for example. We know that a lot of the same cognitive and behavioral concepts are operating, whether you're talking about 12-step or CBT type interventions, and they mobilize the same kinds of mechanisms. In other words, whether you're implementing a 12-step philosophy or another type of philosophy, it tends to mobilize things like coping, motivation, and self-efficacy similarly. So it doesn't have to be 12-step, in my opinion.
I know our program is not 12-step based, and some of our students are real intellectuals, and they like to argue, and they like to analyze. They sometimes have trouble with the programs, and they've really been drawn to smart recovery lately. So is there any research on smart recovery?
Yeah, there is some, not enough. I'm actually trying to research more in terms of smart recovery, and I have a grant right now, an NIH grant under review, which I'm hoping will be funded so we can look at smart recovery much more systematically on a larger scale around the country, because we need more research, as I mentioned, on smart recovery and all these other mutual help groups, which have been around a long time. They're fairly popular, but they've been limited in their growth just because they haven't received the kind of referrals that AA and 12-step communities get from treatment. So it means that, as I mentioned, they've tended not to grow very large because they haven't been getting the clinical referrals, and then they don't grow, so they're less likely to get those clinical referrals. So if we had more research, which I'm hoping to do and others are hoping to do, then we can increase the recovery options for people so that they can start to utilize, if they don't want to go to 12-step groups, they could try things like Smart Recovery or LifeRing or other groups.
We had a question about replacement. Do you have any thoughts about replacement therapy on cognitive functioning and the impact of adding students who are using replacement therapy to an abstinence-based CRP?
So two parts to that question. One is, does like an agonist therapy, I assume the person means buprenorphine or methadone, does it affect cognitive functioning? And is there a kind of a culture clash in terms of having someone on replacement therapy, agonist therapy, be involved in an abstinence-based program? I would say that when these medications are used as prescribed, they should not interfere with cognitive functioning. You should be able to actually enhance cognitive functioning in the sense that there is a stabilization of brain chemicals in the brains of individuals who are beginning that recovery journey from opioid addiction. There is, of course, a culture clash going on currently with these two different approaches to recovery, medication-assisted recovery and the more traditional abstinence-based, usually typically associated with a 12-step orientation. Interestingly, the Hazelden and Betty Ford Foundation has now incorporated both 12-step and agonist therapy, buprenorphine and naloxone, into their treatment program. And they're trying to integrate these two, disparate kinds of historically disparate approaches together. So time will tell how we're able to do that and study that and see if they can be integrated together to see if we can, maximize all of these different tools that can help people get and stay in recovery. There's a lot of evidence to support methadone and buprenorphine naloxone as recovery support tools that can help people stabilize and achieve recovery and keep them alive. And also there's lots of evidence to support 12-step approaches and abstinence-based approaches. So it's trying to find ways that we can meld both of these kinds of resources together and maximize and identify for whom which approach or which combination of approaches are best at which particular times.
That was really cool. I know for me, I tend to have to remind myself, okay, I'm in my own recovery space. I can have an opinion there. Okay, now I'm at work. I need to have a different attitude and opinion here. And so I think for a lot of us who do this work and who are also in recovery and come from a certain pathway to recovery, this is a hard thing for us. And I know we all want to have our students, what's best for them is like our focus, but it's a struggle. And here at Ohio State, we're having conversations about how can we better support students who are using medication-assisted treatment, and they have, issues getting their medication, getting it affordably, getting it timely. So how can we do our part to support that? So I'm anxious to see kind of where the field goes with all of this.
Yeah, me too. Yeah.
So another question we had is, it says, in his recent book, The Sober Truth, Debunking the Bad Science Behind 12-Step Programs and the Rehab Industry, Lance Dodds, a retired professor from Harvard, in your neck of the woods, claims that AA's actual success rate is somewhere between 5 and 8%. What are your thoughts on his findings?
Well, I'm not quite sure where he's getting that from and what he means by success, what the 5 to 8% success rate means. It's never quite detailed. It's, from the research, from what we know about AA and 12-step groups and treatments designed to link patients with these 12-step groups, that they are very potent. They produce benefits which are on par with the benefits derived from professional interventions. And we know that 12-step interventions actually confer typically a greater benefit when we do randomized controlled trials on 12-step interventions, which are designed to link patients with AA and NA, that those interventions do better than things like cognitive behavioral therapy, in part because they link patients to groups in the community like AA and NA, which over time continue to mobilize the same kinds of intrinsic recovery resources, that is to say, coping skills and motivation and self-efficacy. But they do that over time in the community for free. And that's why those treatments tend to show better outcomes, is because of that. Where the 5 to 8%, I don't know exactly where that comes from. I've never found out where that comes from and where he gets it from in the book. And what success actually means. Does that mean someone who goes to AA for 3 months, the success rate, or and whether the success rate means complete abstinence? I don't know what all of that really means. But what I can tell you is that from the scientific literature, over the last 25 years, since the Institute of Medicine called for more research on AA and more rigorous research, that these are the kinds of benefits that we've seen. And this is why there's been a push now around the world to utilize more peer support and direct people to peer support organizations that support recovery like AA, because it tends to improve outcomes and reduce healthcare costs.
There's been a lot of, well, I was going to say bad press, but I guess it depends on your thoughts on it, but a lot of press about 12-step programs and do they work, and so it's been, I feel like my Facebook feed lately has just been blowing up with really intense articles on that. So it's interesting to hear all the research around it.
Yeah,
Go ahead.
No, I was just going to say there's a lot of, things in the press. They're not very well, I've read them too, they're not very well, they're not scientifically based. So people can express their opinion in the press, doesn't mean that it's true. And this is what is often the case. Usually there's someone selling a book or trying to, put their, get their name out there. But it's not based in science, or it's only partially based in science, which creates a bias in terms of what is presented. And this is where, from a public health perspective, it's not very helpful.
Do you think because folks that are in 12-step programs still, are anonymous and they're not writing back, do you think that that's contributing?
Yeah, of course, AA itself often they have a policy of not interfering and not commenting on any of these press stories that come out. So and people in recovery, if they don't speak up, then yeah, there is this kind of impression can last in the public psyche. So there's a negative biasing impression that can persist as a result of newspaper reporting, because oftentimes people, do believe what they read as facts in the newspaper. They believe it to be true. So you have to be very careful about what you read.
Absolutely.
Yeah.
We've got about 4 minutes left, and I have a couple of questions left. And the first is, can you speak to some of the barriers individuals in long-term recovery face when returning to or beginning school?
Well, I think it's, I think there's often a lack of, there's a lack of confidence that is apparent early on when people are returning to school. Will I be able to cope? Will I be able to deal with this? So there's these kind of emotional and psychological doubts which can interfere as a barrier in terms of people accessing and thriving back in school. And there's the, of course, the things we were talking about is the other kinds of risks, which are the substance-related risks in the collegiate environment. Then there's also, I think, the sense of shame and stigma that people still have and carry with them, even when they are in recovery. They may have been in recovery for months or years or even decades, but that stigma can still persist. And so there's a sense of kind of needing to hide something and needing to keep it a secret from other people. So they have this kind of private secret life, which nobody knows about. And this is what collegiate recovery programs are all about, so that people can be open, they can be upfront, they can get validation and support for their status as a recovering person and praise for that as they should be praised. So that's what, these programs can provide and stimulate and facilitate. And that's why I'm so happy that these are growing around the country.
Absolutely. And one final question. So I think historically college campuses have done a lot with prevention, maybe some with intervention. In the last 30 years, they've been doing some work around recovery, but what's missing is that treatment piece. So what advice do you have for schools to create a model of treatment to finally have that full continuum of care on a college campus?
It's interesting. You can go, should a college campus be providing treatment for substance use disorder is the question. And there are places around the country that are doing that. They are providing a full continuum of care on some large college campuses, university campuses around the country. And it's a really, an empirical question and a cost question as well as a philosophical one. Is what's the best way to deal with this endemic public health problem that we have, and in particular on college campuses. So Yeah, I don't know, what the best way to do that is. Other people might say, well, we should deal with education here. We can refer people out to a local treatment facility that can provide treatment and have them reconnect. Maybe that's the more efficient and as effective way. We just don't know right now. Is there an added gain to providing treatment on college campuses? That's something that I think we need to investigate more.
Awesome. Well, thank you so much, Dr. John Kelly, for being with us today. I hope everyone is walking away with some great information to take back to their collegiate recovery community. So we hope that you all stay in touch with the Higher Ed Center. We're on Facebook, Twitter, Instagram, YouTube, you name it, we're on it. And I hope you all join us this August 4th, 5th, and 6th for the national meeting here in Columbus, Ohio. And y'all have a great day. Thank you so much.